Hello, everyone. I knew Dror is going to be talking about myocarditis, so I didn't talk about that, even though it's a fascinating aspect of dealing with pandemic and vaccination. But the point of vaccination itself and whether providing mass vaccines to the public is a research adventure or public health surveillance. And I'll go over where we were and then some guidelines from WHO on the topic. And I just want to emphasize that what Dror said about the having active surveillance was actually Amelia Anis' idea. She is the head of epidemiology division, and so all the credit is due to her. So if we go back to the time when we were dealing with COVID-19 around the vaccination, this is the epidemic curve in September, December. And after having our second wave with increasing cases and a lockdown and started to get out of the lockdown. So we finished the lockdown and then started to open economy step by step. We started to see an increase again in cases. And we had a full kind of program of how we open every 2 weeks another sector and couldn't even complete this exit plan. And we knew that as long as we don't have countermeasures, which means vaccinations or drugs, the more cases that we'll have, and some percentage of them, 0.8 to 1%, will die, the more cases we'll have, the mortality will rise. It's mathematics. And so mortality did rise in the third wave. And with a reproductive number of 1.2, we know that the numbers are replicating every 2 weeks. So if on a certain day we have 2,000 cases, 2 weeks from then we'll have 4,000, and 2 weeks from then we'll have 8,000, and it's just replicating, and we don't have a good way of stopping this except for very extreme measure of lockdowns and distancing. And as you can see here in the slide, we actually got to a reproductive number of 1.4, which means we're doubling every week or 10 days. So very quickly. And this is taking from a presentation we gave to the cabinet, to the Corona cabinet, on December 6th, basically saying this is mathematics. It's exponential rise. If we just look at the date of December 20th, the second point, we know that at that point we were anticipating, the dotted line is the forecasting based on the number of cases that we have and the reproductive number, and knowing what percentage of them will die. We would just look at the rise because we know it's coming. We're looking at the wave, and we can calculate and say on a certain day we'll have over 3,000 confirmed cases and over 450 severe cases. And then when we actually plotted the number of cases that we got, because there were no distancing or any kind of restriction provided at that point, we just saw this purple line just going over the dotted line. So we knew this is mathematics. It's going that way. The only way to change it is by certain countermeasures, vaccine, drugs. Drugs were not available at that point in time. And so the vaccination campaign, as Joe said, started on December 20th. This is the first shipment. And what we saw not immediately, it took a couple of months. But what we did see is that the number of cases were starting to come down, even though we opened economy. So here we had not an exit plan of 9 steps. We had an exit plan of 3, but we were able to complete them. So the more people got vaccinated, the less infection communication was, and we were able to open economy. And we saw it in different measures. We saw it in the Ramzor indicator, the traffic light. It's weird to say traffic light. The Madad Ramzor, we saw, which is an indicator for disease spread across communities. Usually what we were looking at that is geographical communities. So if we started at that point with over 80% of our population in December had been in red or orange measures, which mean high level of infection, it started to come down. And what was more important is that we actually saw it in the severe cases. So this is the graph showing new daily new severe critical condition admissions. We got to a point where we had 180 cases a day of severe cases of COVID-19. And you see that graph slowly coming down. It takes longer because that impact takes longer than just reducing the confirmed cases, but it is coming down. And you see that half of the cases or 40% of the cases at some points were young people. On ventilated patients, you see it took longer for the curve to be improved. But this is because people can be ventilated for a longer period of time. And here we had 25 to 50% in different periods of time of people under the age of 60 who were ventilated with COVID-19. And on ECMO, took longer because once someone is on ECMO, then they can be on it for weeks at a time. So patients on ECMO stayed longer, and it took longer to improve that curve. But 70 to 95% of them were under the age of 60. And part of it is a bias because you would put someone on ECMO because he's younger, has more chances. But just to say that this is not influenza. This is not a disease of old people and very frail people. It's not. This is not what we saw at that point in time in the pandemic. And so the daily COVID-related mortality started to come down. And what we saw when we looked at it specifically based on vaccination status is the people who continued to die from COVID was mostly the people who were unvaccinated. If we just take a stop for a minute and look at the mortality up until today from COVID-19, you can see that most of the mortality is among the over 60, roughly 92%. But we had roughly 1,000 people who were under the age of 60 who died. So once we saw the impact of this vaccination campaign, we published this paper. It was published in The Lancet. Looking at, this is, I think, the iconic graph from it, looking at different age groups. So every cube is a different age group. And the brighter blue means that they got one vaccination, and the darker blue means that they got 2 vaccinations. And the fine red line showing the infection rate of that same group. So obviously it's a bit confusing because someone who is 40 can infect someone who is 60, right? So they're not walking in real world just in their groups, but it's trying to show the impact, whether it had the same impact on different age groups. And you can see that the more people are being vaccinated, the less infection spread, the infection incidence of that group is coming down, and we see it in all age groups. And so now the question is, for this conference, is this research? Is this surveillance data? How do we call it? So this is guidelines from the WHO on ethical issues in public health surveillance. And it was published not now, but in 2017. And what they describe there is that actually in public health, we have a lot of surveillance types. We can look at the left side, which is communicable disease, whether it's COVID or measles or whatever communicable disease there is, but we're actually tracking also non-communicable diseases, and we're actually tracking environmental factors and other things, and each one of them has their own objectives and their data sources, and the analysis could be different. So the role of public health to do surveillance is broad. This is what we do. We're epidemiologists. So for the ethic of surveillance, not every public health surveillance is actually epidemiological research. And this is defined very well in that paper. So how do we define research? Research is more focused usually on individuals, requires informed consent, require approval from an ethical review board. It's individualized personal data. Public health surveillance, on the other hand, what we look at as the community. The community is the subject of concern. It's one of our responsibilities in public health to do that type of surveillance. And you saw not just in communicable diseases, but obviously when we're talking about pandemic or outbreak investigation or emergency situations, there is an exemption from an ethical review board because we cannot wait for an approval to look at the data that can save lives. So we're looking at data that is coming to us. We're not doing anything specific to bring people to be on two sides, one vaccinated, one not vaccinated. We're offering vaccines to everyone, obviously encouraging them to get vaccine because we have a pandemic and people are dying, as I just showed you. But it's not a typical research when we're trying to do two cohorts and compare them, which for epidemiological studies, otherwise we could do exactly that. When we look at public health ethics, there are several things that we need to look on. First of all, our purpose is the common good. Our purpose is to do the surveillance that will be helpful for the community, helpful for the population. The surveillance is important because of equity reasons. If we don't track, we won't be able to know that there are some groups who are suffering more, that there are some groups who don't have access to certain treatments or vaccinations. When we were following this, it became important very early on to track vaccination status among different, not genders, different sectors. And then we could see that the information about vaccinations is not reaching everywhere the same. And we need to improve our information strategies, information sharing strategies, or go online or go to different populations and explain in their platform what they need to know and be available to for their questions. So the point of equity is important in public health. Respect others. When we do this, we still need to be respectful of people's rights and making sure that we're trying to do as much as we can not to go overboard. When we had the third wave and the vaccination campaign started, this was after hotels were closed for roughly 8 months or something like that, 10 months, a long time, from March, basically. Hotels were closed. And when vaccination campaign started, one of the ideas that someone suggested, I think even from the hotel business group, is let's open hotels just for vaccinated individuals, just for them. Let's just do that. And we said, no, this is not ethical. There are some people who would not want to get vaccines. Some people may not be able to get vaccines because side effects or contraindications or whatever. And it's not ethical to provide places where only vaccinated individuals can enter. And even when we initiated the Green Pass was open with negative test results. And the Green Pass itself is not showing your vaccination status. It was purposefully done in order for you to show something that does not describe whether you are a recovered individual, vaccinated, or just did a negative test. We could have said, show your vaccination card. And we said, no, that's a confidential information of the person. Let's do a Green Pass that allows people to enter. And the reason for that was exactly that. We were trying to open economy. We were trying to open places and allow for people to come in hundreds and thousands of numbers, which was not available previously. And the way to do it is to try to create lower risk among those, whether because you're coming with a vaccination, with a vaccinated or recovered individual or a negative test. So holding on to the fact that you need to still respect the fact that not everyone will be vaccinated is important. You need to respect the fact that you don't want to share their information. It's confidential. The fourth criteria, or the fourth point on public health ethics is the good governance. It's the fact that we need to be transparent. And I think one of the, in my mind, one of the most transparent countries was Israel, with the dashboard, with all the information in there. And sure, people can always come and say, well, the dashboard is not, when we change things, for example, we had to change definition with the booster. So obviously when you need to correct things on the IT system, it takes longer. And then there is this big wave of the dashboard is not transparent, is not showing the right data. Yes, it takes time to correct for changes along the way. But I think we provided the data as transparently as we could. And for the adverse events, by the way, all the information on the adverse events is on the Ministry of Health website, including information talking about the myocarditis, including things that people reported on their own privately. So everything is out there. And so the fact of being transparent while we are doing this is extremely important. So they're putting guidelines in that paper about surveillance and what we need to make sure that we're thinking of when we're doing public health surveillance and it's not research. So I'll go over quickly. The obligation for a clear purpose and plan. I think that was clear. Ethical, ensure ethical surveillance. We have an IRB approval process, but as you can see, when you're trying to do something to decrease in a pandemic, in an emergency use, you may not need consent form to do that. So it will come in a minute. The surveillance data is important to collect only for legitimate public health purpose. The data collected should be in sufficient quality. So if you're collecting data and it's garbage in, it's going to be garbage out, and it's probably worse than just not collecting. But we knew that the data here is, and we worked hard on it for the data to be of high quality. As we talked about, it needs to be transparent, support equity, support other countries in their efforts, because not all countries have the same resources. Values and concerns of communities must be heard. And in Magen Israel, in the group that was leading the COVID-19 response, there are desks of Orthodox Jews, Arabs, general population, trying to hear what they need, trying to be attentive to things that they are saying about the data itself and about measures needs to be taken. Minimize any harm that there would be any leak from the data. Some of the data, and it could be identifiable. Some of the data could be identifiable. We have to make sure that it's not leaked in any way. We have to make sure that we look specifically on groups that have higher propensity to adverse events or adverse effects from the disease. So looking specifically on Magen Avot ve'Imahot, on the elderly population, was extremely important in that perspective. Securing the data, even though it's identifiable, individualized data could be collected, could be identified, but again, needs to be secured. And informed consent is not ethically required when you're trying to deal with a pandemic in an emergency use when people are dying. Results communication can always improve in that, but part of the announcement to the media was that, to make sure that the public knows what we're following and knows the data, sharing the data nationally and internationally. We actually felt truly obligated sharing the data. We saw things because the public healthcare system in Israel is so strong and was able to vaccinate very quickly. We were the first in the world to see things that others didn't see, whether it was the myocarditis, the need for a booster, the ethical, we have an ethical need to share it with the world. We can't just do it amongst ourselves and not tell anyone else. So this is part of surveillance guidelines. Data has to be timely shared, and sharing for research. This is something that we actually try to do better, and I hope in the future we can even do better than that, share the data with researchers, obviously anonymized and everything, but share the data so other people can also, in a secure way, look at the data themselves. We have other topics to challenges ahead, which is the fact that some non-state actors are collecting data, that we're going into a world of big data, a lot of data that is going to be there. And some of this is personal information from the private sector, from watches on people's hands, and how are we going to deal with that? So I think, to me, I want to thank you for the attention. I think what we saw in the pandemic is that we had a tool for the first time that can allow us not to use lockdown, not to close schools, not to do all the things that Israel suffered a lot from them. There were high consequences from those restriction steps. And once we had that tool, it's our obligation in public health to follow it and monitor it and see if it's working or not, and then share that data with the Israeli citizens and with the world. Thank you.